Right now, COVID cases are down and people are relaxed. They're looking at other things, they're thinking about other things, their mind is elsewhere. But it won't always be that way. Right now, across Europe, a number of nations have started to see a little bit of an uptick in cases. And I suspect, I don't know for sure, but I suspect that at some point we will get an uptick in cases. It's only a matter of time. I don't know exactly when, but I think it will happen. That'll happen because vaccine effectiveness of the booster against symptomatic SARS-CoV-2 goes down with time. And vaccine effectiveness of the primary vaccination series goes down with time. And even to some degree, people who've had the virus and cleared the virus, they get further and further out, they may get reinfected and have a milder symptomatic version of the disease. All these things coalesce to cases are going to go up. And the other thing that's going to lead to more cases is more tests. Everyone's got 25 tests. The cupboards are full of tests now. Before, hard to find a test, but now we all have tests. You put these things together, and you will get a rise in cases at some point. Now, what do we do when the cases go up? That's the question, and that's the topic of my Substack post, when COVID cases climb. And I have a policy prescription for what to do then. I worry that we're not going to follow my policy prescription, and we're going to follow, what people like to do. Unfortunately, what people like to do is not always the most helpful. So let me run through my policy prescription. This is available on my Substack down below. You should subscribe if you don't already. It's a good place to get my thoughts. Here it goes. What do we do when COVID cases climb? Number 1, don't test an asymptomatic person. Now, with Vlad Kogan and I, we wrote an article in Slate where we make the case that asymptomatic testing within schools is not very helpful. And I want to extend that to almost all settings. Most healthy people who are asymptomatic should not get tested. Now, I want to put some carve-outs for maybe protocols around, very immunosuppressed wards of the hospital, protocols around nursing homes. We can rethink that separately. But let's just talk about everyday people. If you're asymptomatic, you should not be tested. And these companies should stop their asymptomatic testing programs. Why? People who feel ill should get tested, but the whole idea behind testing people who are asymptomatic is that by finding them, identifying them, and telling them that you got COVID, you will slow the spread across the population. But if we're perfectly honest, we don't actually have evidence that that's the case. The way you would do that is you would do a study, I think. You could get a bunch of businesses who have this weekly screening, and you randomly assign them to do it or not to do it. And then you measure how many cases are among their employees. And I think it might be sobering. There are a number of reasons why the practice of screening with asymptomatic tests and telling people that they ought to change their behavior won't work. 1, the test has limitations in the test characteristics. It might miss some cases or have some false positives. That's less of a problem, but missing some cases is not totally out of the question, especially if it's very early in the course of their illness. And the other problem is people don't change their behavior as you would like them to. Sometimes they cannot. They cannot afford to change their behavior. And those two things together might mean your policy is actually disruptive, but doesn't actually accomplish anything. They still engage in different behaviors that spread the virus in a different way. They may hang out outside of work anyway. The next thing, number 2, I don't think we should get back into reinstituting a cloth mask mandate for someone else. At this point, if anyone wants to wear a high-quality mask, they can do it. To be honest, you could always have worn whatever mask you want in this world. There's no, for as long as I've lived, you can wear whatever mask you want. And you can do that going forward. And if you want to wear a high-quality respirator mask, or you want to wear whatever kind of gas mask you prefer, you can wear whatever mask you want. But there's no reason to compel someone else to wear a mask that doesn't offer a lot of filtration or a lot of protection. In randomized control trials in Bangladesh, the arm that had cloth masking didn't work. And yet, to my knowledge, and anyone can correct me if I'm wrong in the comments, there has not been a single community policy in the United States, or even, no, Germany is the one exception. I think Germany actually recommended surgical masking. But in the entire United States, every community mask mandate was for a cloth mask. Now, of course, hospitals have had different rules, and different employers might have different rules. But I'm talking about a community mask mandate. It's always been a cloth mask. And that's the mask that didn't work in Bangladesh. And that's a mask that I struggle to understand what the purpose is if the people who wish to are wearing the N95s. I don't know of any study that would show me that there is an additional population level benefit by mandating someone else wear a cloth mask when you yourself are correctly wearing a fit N95 or KF94, whatever you want. So I think it's fair to say that people should be free to do whatever they want, but compelling someone else to wear this It's not a good idea. I also think it's not good from a policy standpoint. It's going to breed more and more animosity, more and more polarization. And I think it's not going to serve the goal. It's not where our focus should be. I'll come to where our focus should be. Number 3, don't close schools again. Closing schools was a catastrophic policy failure. I've been saying that since the fall of 2020. I came to the conclusion it was a catastrophic policy failure. I've been pushing on that hard, pushed on it hard in the spring. Should never happen again. Should never happen again. In the United Kingdom, we have zero prevalence data that even though they had school closure, the high 90 percentage points of kids ended up getting COVID anyway. In the United States, it's in the 60s, according to the CDC, and in a Washington Post article where that is documented. All the people who got it anyway, despite the closure, could not have possibly benefited from the policy. There's a paper by Chris Whaley and Niraj Sood that shows the upper bound estimate of how much it could have slowed spread in the community, which is very, very marginal. I think the 25th to 75th percentile shift is 0.3 cases per 10,000. Go back on this channel. I interviewed both those authors. They're from the University of Southern California. It is a terrible decision. It's a poor trade-off. Don't ever do it again. Number 4, this is what we ought to do. Boost elderly and vulnerable people, and boost them yesterday. Boost elderly and vulnerable people. Give them vaccine, make sure there's no unvaccinated, non-immune older person. That's what you ought to do. If Hong Kong were doing that right now, they'd be in much better shape. It's about vaccinating the right people, the people who have tremendous risk of death. That's what you need to focus on. Number 5, don't push vaccine mandates at very young ages. I think it's an incredibly polarizing topic. I've discussed it elsewhere in SF Gate, in U.S. News and World Report, in, to some degree, those articles I wrote in Tablet. I'll push that aside for now. Number 6, do not consider business closures again. The effect was always disputed. It's incredibly polarizing. And instead of that, you can recommend to businesses some sensible strategies to improve ventilation if we so wish. We don't need to close them. Number 7, hospital capacity. We need to expand hospital capacity. Expand it, expand it, expand it. It needs to be ready to be expanded. What that means is, to some degree, if we're doing no value medical practices right now, we need to cut those out. There are no value medical practices. I wrote a book on the topic. It's called Ending Medical Reversal. It's about things doctors do that just don't work. We need to stop doing those things. There are many of those things still extant. I have a paper out in eLife from a couple years ago about medical reversals. It gets into what those things are. Number 8, hire back healthcare workers who are fired because of vaccine mandate policies. That wasn't very fair, it wasn't very just, and it's not very helpful. We need those people back. We need them as employees. So entice them back. Number 9, give credit for natural immunity. We heard from Paul Offit in an interview with ZDogg that the administration had a straw poll, and they almost gave credit for natural immunity as a vaccine equivalent. We need to figure out what it should be equivalent to. I don't think you should use antibodies or symptomatic disease to find the equivalence. You should use the rate of subsequent hospitalization. Having had and cleared the infection is the equivalent of X number of doses in terms of protecting you from subsequent severe infection. That's the question. We have data from California and New York State in MMWR that suggests it's going to be really, really good. It's going to count for at least a few doses, I think. And it ought to. It makes sense for it to count. Number 10, clearly delineate hospitalizations from COVID and with COVID. We need that information yesterday. We need to know who's hospitalized from COVID, with COVID, kids, adults. Enough of this already. Sort that out. What are you doing? What are you doing, CDC? Number 11, run a cluster randomized trial of COVID testing upon hospital entry. I think we need to know this universal policy of swabbing everyone. Is that actually a policy that's beneficial, or is it something like Star ICU or Bug? Is it not beneficial? Number 12, publicly report all outcomes in real time, hospitalizations, deaths, COVIDs, excess mortality. That needs to be a continuous stream up to the minute. What kind of society is this that this is lagging by 2 weeks? Is this a advanced society, a modern society, or fail society? Because you need to get your data up fast yesterday. Also, CDC, enough of this gatekeeping of data. You just put all your data on the website. You let other people think about it. Just put it there. I'll do the thinking about it. I don't need you to think about it for me. I prefer to think about it myself. Just make all the data available. No more hiding data, as was detailed by Apurva Manvi in an article in the New York Times, hiding wastewater data, etc. You can pull that up. Run serial seroprevalence and random PCR testing. You can read more about that. That's an important strategy. Number 14, power Omicron-specific vaccine trials for hospitalization and death. I just saw the Pfizer CEO, Albert Bourla. He says, good news, you get to get your fourth dose. You get your fourth dose soon. I said, you know what? I like the good old days where we tell you if we need the dose. You don't tell us, Mr. CEO of Pfizer. Not that I don't trust you, but I don't. I need to see some data. I want you to run a randomized control trial and show me you further reduce severe disease or hospitalization. No more antibody titer endpoints. No more symptomatic disease where it could be a scratchy throat. I need to see some real endpoints. Or no go. Number 15. Tom Brady's back. So why not Gruber and Krause at FDA? Brady can come back, so Gruber and Krause need to come back to the FDA. It'll build some credibility. 16 is a little bit of a joke. 17, increase insurance coverage. I think it will help to have Medicaid expansion. 18, expand paid sick leave. I mean, there's no reason, we're forgetting the forest for the trees. People who feel sick, they should be empowered to stay home when they're sick. We don't want them at work anyway. We probably should never have had them there. But if you're not sick, you don't need to be testing all the time and disrupting the workflow. And those are the key principles. COVID cases are going to eventually rise. I'm afraid that that's going to be true. I suspect we're going to enter pandemonium because it's a lot easier for policymakers to look strong and say, well, we got the kids back in the cloth masks, rather than to do something correct, which is, we're actually boosting those nursing homes yesterday just in case. And we have a new strategy for boosting. By the way, why are all the boosting? It doesn't have to be all in a wave with a date. What you should do is, I would imagine, you should get all the people who are eligible for boosters and have staggered dates of boosting them. So you boost them across a period of several months so that the person who's wearing off vaccine effectiveness, it's not everyone all at once. You didn't just boost them all before a March 31st date so they all wear off 4 months later. You sort of stagger it and spread it so that there's some overlapping immunity. I think that would be more sensible. Anyway, these are my thoughts. This is when COVID cases climb. It's on my Substack. I suspect they will climb. And I think it will be chaotic. And I think the reason it's so fractured is that the real failure of science has been not to generate evidence. We know very little of which of these things actually work and which don't work. I think the ones that are increasingly off the table are not off the table because someone proved that they don't work, although I suspect that they don't work, but they're off the table because they're politically unpopular. That's why they're off the table. And so I think that as much as we can collect and actually sort out what works going forward, that would be sensible. As much as we can avoid the things that just look good or visible and focus on the things that actually hit the high-risk people, that would be sensible. And that's the themes of my Substack post when COVID cases climb. So if you like this video, you know what to do. Like, subscribe, comment, leave a message below. Until next time.